Welcome to this comprehensive NClEX review on lung cancer. This is a critical topic for your nursing exams and clinical practice, focusing on pathophysiology, assessment, and nursing priorities. Lung cancer is a malignant tumor arising from the respiratory epithelium, most commonly within the bronchi. It represents a significant health challenge globally. The process begins when normal lung cells become abnormal, growing uncontrollably, and eventually leading to significant airway obstruction and tissue damage. This uncontrolled growth doesn't stay localized. It eventually spreads or metastasizes to other vital organs, which we will discuss in detail shortly. Classification is absolutely vital for the NClEX. You must distinguish between the two major types, small cell lung cancer and non-small cell lung cancer. Small cell lung cancer, or SCLC, is less common but exceptionally aggressive. It is known for its rapid growth and early metastasis in the disease course. Non-small cell lung cancer is far more common. It includes adenocarcinoma, squamous cell carcinoma, and large cell carcinoma, each with distinct characteristics. A key NClEX insight to remember. The most common site for these malignant tumors is the bronchial epithelium. Take note of this for your exams. Because it is often diagnosed in later stages, the 5-year survival rate remains low at about 13%. Remember the exam trick: late diagnosis equals poor prognosis. The pathophysiology usually begins with chronic irritation. Smoking is the leading cause, triggering destructive changes in the delicate epithelial cells. This progression follows a specific path. Metaplasia leads to dysplasia, then to carcinoma in situ, and finally develops into invasive cancer. As the tumor grows, it causes airway obstruction. This leads to distal lung collapse, known as atelectasis, which significantly impairs gas exchange. Metastasis occurs early and widely, spreading primarily to the lymph nodes, the brain, the liver, bones, and the adrenal glands. In clinical practice, a patient might present with bone pain or neurological symptoms as their first sign, rather than traditional lung symptoms. The primary cause is tobacco smoking, which is linked to approximately 90% of all lung cancer cases. It is the most significant modifiable risk factor. Other significant risks include exposure to secondhand smoke, radon gas, and industrial toxins like asbestos, arsenic, and coal dust. Let's move into assessment. Recognizing the signs and symptoms is crucial for early intervention and priority nursing care. Assessment can be challenging because early-stage lung cancer is often asymptomatic, meaning the patient shows no signs of illness initially. As it progresses, watch for a chronic cough or a change in a pre-existing cough, along with hemoptysis, which is blood-tinged sputum. Patients commonly experience dyspnea, audible wheezing, and you may find decreased or even absent breath sounds during your lung auscultation. Don't ignore systemic symptoms. Persistent fatigue, rapid unexplained weight loss, and anorexia are common markers of advanced disease. Advanced cancer can manifest as chest or abdominal pain, persistent hoarseness, dysphagia, and visibly enlarged lymph nodes in the neck area. Severe clinical signs that require immediate attention include the use of accessory muscles for breathing, nasal flaring, and digital clubbing. A major NClEX priority is superior vena cava syndrome. Look for edema of the face and neck, along with dilated veins on the chest wall. To confirm the diagnosis, doctors use sputum cytology to detect malignant cells and bronchoscopy to visually identify the tumor site. A needle biopsy is highly effective, confirming the diagnosis in about 80% of cases. Tissue biopsy is essential for accurate staging. Imaging studies are standard. Chest X-rays can show lesions, while CT scans provide detailed information on tumor size and spread. PET scans are invaluable for detecting metastasis, while MRI and bone scans evaluate the extent of tumor invasion into other tissues. Blood tests might reveal elevated serum calcium if bone metastasis is present. ABGs often show hypercapnia, hypoxia, and respiratory acidosis. Treatments are multimodal, involving chemotherapy, targeted therapy, immunotherapy, and potentially life-altering surgery. Chemotherapy agents like carboplatin and cisplatin are commonly used to target and destroy rapidly dividing cancer cells. Targeted therapies and immunotherapies such as nivolumab and pembrolizumab work by helping the immune system fight the cancer. Supportive care is essential. This includes antiemetics for nausea, analgesics for pain control, and oxygen therapy for managing hypoxia. Surgical options include wedge resection, lobectomy, or a complete pneumonectomy, where an entire lung is surgically removed. Nursing interventions prioritize the airway. Always monitor vital signs and respiratory status to maintain a patent and clear airway. Provide comprehensive care by monitoring daily weights, maintaining skin integrity, and turning the patient frequently to prevent complications. Support nutrition with a high-calorie diet and small, frequent meals. Never forget to provide emotional and psychological support to the patient and family. In clinical thinking, stay alert for red flags like hemoptysis, sudden dyspnea, and the facial swelling associated with SVC syndrome. For the exam, if you see a smoker with a chronic cough and unexplained weight loss, your priority should be lung cancer assessment. Thanks for watching. Please subscribe and share for more nursing videos.